Good morning, and welcome back to Good Samaritan Facebook Live. My name is Dr. Scott Stine. I'm a family practice physician and Chief Medical Officer for Good Samaritan Physician Network here in Vincennes, Indiana. Joined again by Adam Thacker, who's our Chief Operating Officer of Good Samaritan Hospital. We'll be giving you our weekly update on COVID-19 in our community, talking a little bit about changes that have happened over the course of the past week or so with some state guidance as far as what stage we're in. Of course, we'll talk about testing and then talk a little bit about what's coming up as far as vaccines, specifically our vaccine flu clinic, so forth coming up. So just to lead off with our statistics every week, the thing that we keep going back and focusing on is positivity rate and then, of course, total number of active patients. So last week we were in the 60 range as far as active cases, now down about 50 or so as far as active cases. And that positivity rate, which is probably the most important thing, is the 7-day unique individual positivity rate, which is basically looking at individuals specifically not that haven't been retested or so. Right. And so we were at, the non-unique individuals, we were like 5.7 or so. Right. And then the newest one as far as the unique individuals this past week.
Yeah, we dropped to 13.9%. So over the last couple of weeks, we've hovered in the 16 to 18 range, even up to 19. So seeing that come down a little bit. Now, keep in mind that as the data is reported on a Monday, weekend numbers will be rolling in. So we would expect at noon today, when the dashboard is updated, that we see a little bit of an uptick, but seeing our active cases go down as well as both positivity rates trending in the right direction says that we're moving the needle where it needs to, and maybe on the downward slope of the post-Labor Day surge that we seem to have a trend with seeing on holidays.
And we've had a bit of a corridor of our county and our two neighboring counties to the east, and our numbers are matching up pretty closely now. They had been a little bit higher than we were. We're all pretty much matched up in that 14 or below range on the unique individuals. But one important thing to look at is hospitalizations. If we look at that curve of hospitalizations going back to basically post-4th of July is when we saw that curve start to slope upward, and it has been pretty steep in the past 4 weeks or so. Right. The important thing to look at, though, that we discussed a little bit earlier is what group of people tend to be positive the most, meaning what members of our population, what members of our community tend to be positive.
Yeah, we were talking just before coming on, and 60% of our total positive cases are age 20 to 50. And then when we look at from a statistical standpoint with risk, once we get over that age of 60, we know that at higher risk for hospitalization, for longer term effects, and certainly those with comorbidities around heart and lung disease have a more difficult time recovering from coronavirus. So certainly want to continue to maintain all of our precautions that we have in place with social distancing, hand hygiene, the mask mandate that stays in effect at least through October 17th. And really, as we've talked, that's going to continue for a much longer period of time. But we continue to get updates from the governor and moving that down. But that population, that 20 to 50, that is 60% of our positive. Most of them are recovering at home, which is what we like to see. So from a hospital resource standpoint, our resources remain very strong, both from a equipment and facility standpoint, as well as personnel and taking care of these patients, because it does take quite a toll on our staff. They're in the trenches every day, and taking care of coronavirus patients is new to all of us, and we're learning and continuing to go through that as a nation and really as a world. But it is unique. Patients are staying in the hospital longer. The donning and doffing of protective equipment takes more time. So it's a tasking process that our staff are working through.
And one of the interesting things about that age range you're talking about is very few kids showing up positive with this, and the school systems are doing very well with this.
Excellent.
We had a lot of people that early on were like, oh my gosh, all the kids are going to go back to school and they're going to spread their bugs around like we do every year. And really what we've seen is nearly a complete absence of that.
Right.
And so it's very encouraging. We'd like to congratulate all the schools, all the students, all the teachers, superintendents, and principals who have done a really good job. And I think probably the key to that is a very regimented job of that. No different than here in the hospital, where we are very strict about how we do our precautions. The schools have done an excellent job with that. And so we've seen a very small percentage of cases that have been in that 20 and under population. So that's encouraging. We will continue to work with the schools over the next several weeks. So we meet with them every few weeks to see how things are going. But really, things have gone better within our school systems, I think, than a lot of people were concerned about 6 or 8 weeks ago.
Sure. Yeah, in our region, most schools back in a live on-site capacity. I know throughout the state, other areas such as Indianapolis,
Yep.
I don't believe until last week or possibly this week, we're going back to live classes. But we've been able to do that and offer that environment for school-age children, which is excellent. And the total number of positive cases in Knox County school age has been very, very low. I know there's been discussion of a dashboard coming out through the Indiana State Department of Health specific to schools. I haven't seen that information yet, but we'll fare very well in that regard. And schools have been very proactive in changing their processes. I think that it's hard to imagine unless you're in healthcare or now the school system or a large employer, the massive undertaking that is required for putting in processes for sanitation and disinfection on a regular basis, as well as monitoring masking and all of those aspects. So it really is a monumental effort.
And one of the things that Adam alluded to earlier was the back on track plan and kind of where we were, which was we were on stage 4 and then we went to 4.5
Right.
and then we have been anticipating moving on to stage 5. Well, that was announced that started this past weekend. So on Saturday that we moved on to stage 5. And it's important to realize that each time that we meet with everyone every week, we talk specifically about our local conditions. And while the state has basically announced that we can go back to stage 5 and that increases crowd sizes and things like that, I think a point that we want to get across is our numbers, our cases, everything has lagged behind. If we look back to March, April, and May, where the population centers and so forth were seeing their surge, we had virtually no cases at all at that time. And what we've really seen is post 4th of July and our last couple holidays, we've seen those numbers come up. And so although we're seeing the state return back to stage 5, which would be considered normal, what we want to really encourage people is that we still need to be very cautious over the course of the next several weeks or so, because we still are seeing a higher percentage of hospitalizations, and we're still seeing a number more cases than what the population centers have had. So I think it's important to realize that while that has changed, we still want to be very cautious locally.
Sure. Yeah, it's been somewhat of a 180. March and April, central Indiana, the metro area was getting hit really hard, and we were seeing a very low number of cases and very, very few hospitalizations. And then fast forward to this fall, they're seeing that downward trend, actually lower numbers than ours when you look at positivity, and we've seen somewhat of that surge in our region in southwest Indiana. So as we move to stage 5, as Dr. Stine mentioned, initially stage 5 was no mask, we're free and clear. It is return to all normal activities. What stage 5 looks like today is mask mandate is still in place, as I mentioned, at least through mid-October, and anticipated that will continue. Gatherings of 250 now moves to 500, so anything over 500 requires the health department approval. And the caveat with that is all gatherings, especially indoors, still require social distancing, masking, all of those precautions that we talk about. And that's something that as a community we really have to stay very true to as we move forward into the fall, because we mentioned we're going to talk about vaccine, and we are still on the very front end of a flu season. And as that picks up, we want to be as cautious as possible, because not only are those measures that we talk about a precaution and safety for coronavirus, but also for influenza and other respiratory viruses that are going to continue to increase in commonality as we move into the colder season.
And I think that's a really important point that Adam makes, which is as we move into the colder season, which means more people are driven indoors, which means there are less outdoor activities. The flu doesn't just erupt in the winter because that's its favorite season. It erupts in the winter primarily because of us and our transmission of the virus, and because we're all indoors, and because it's easier to spread those things around indoors. Now, one of the interesting things that we have seen with universal masking has been that we've seen less childhood illnesses, we have seen less colds, we've seen less of our typical viral infections, hand, foot, and mouth, things like that we would normally see this time of year in the first couple weeks of school, because of the universal precautions that everybody has been undergoing. That being said, that needs to be even more strictly followed as we go into these winter months, as the temperature gets colder, as everybody goes inside, because that's how we spread this around. As we had mentioned last week, we had seen a few cases of influenza already, which is very early for this region of the country. But the good news is the flu vaccine came out a few weeks earlier this year than it typically would. It's being distributed throughout our retail pharmacies, also throughout our clinic. And then we have a flu clinic that we have organized coming up as well, correct?
Our MCB pediatric office is already hosting some flu clinics and will continue to do so through weekends in October. And then the week of October 14th through the 20th, we have a number of drive-through, evening, weekend offerings that we'll be getting that information out through social media, on our website, and through your primary care office. You can request that information as well, or certainly you can go to the office and be able to get vaccinated through that process. But whether it's a Good Samaritan flu clinic or the CVS, the Walmarts, wherever that happens, our push from a public health standpoint is get the flu vaccine, whether it's Good Samaritan providing that service or not.
And there's lots of questions about what flu vaccine should I get. So our population that's 65 and over, we would really prefer to get the higher dose flu vaccine if at all possible. It's very early in the flu vaccination season. We're really trying to push people to get out there and get it early. There is no such thing as getting it too early. So while that used to be a concept that was taught to people and to patients as well, that, well, you probably shouldn't get it in September, that's a little early, maybe not get it in October, get it in November. Any time is a good time to get a flu vaccine. That has been studied quite extensively to say that the antibodies that you form usually take a couple weeks to form from the time you get the vaccine, and then they are long-lasting throughout the entire season. So any time now is a good time to get a flu vaccine. As Adam said, we really want everybody to get out and really think about what it means to get a flu vaccine this year. A lot of people who might say, oh, I'm not terribly worried about getting influenza, kind of have to think of it in a term of, well, what if I get a febrile illness, I have a fever, and I am concerned about getting coronavirus? That testing process takes a little bit of time, as we know, and you'll likely have to be away from work or away from school. And that quarantine process, that's one more thing that we can cross off the list that we know potentially you won't get. So we would encourage everybody to get out and get their flu vaccine now. The other thing that's important, although not seasonal, is pneumonia vaccine for people who are at risk, who have chronic lung disease, immune suppression problems, diabetes, kidney disease. We want to make sure that those individuals have had their pneumonia vaccine and make sure that it's boosted. And that's available all the time at our offices, through the hospital, the health department, and also through our retail pharmacies. The other thing that we talk about with vaccines is what's coming in terms of coronavirus vaccine. And although we don't have any solid dates on everything, we've gotten some guidance from the government that says, hey, be prepared.
Yeah. And that be prepared was by the end of October. Be prepared if a vaccine was available in November. Whether that will happen or not remains to be seen. I think as we've talked about it, we think it may be a little bit later, but we'll be prepared to roll that out. Part of our drive-through and vaccination plan for influenza that's a little bit different this year is also our practice, if you will, to prepare for rolling out a coronavirus vaccine. We're also doing that with our employees a little bit differently, in a mass vaccination in a single day effort to be able to roll that out. What we do know is that there are 8 vaccines that are going through clinical trials, being evaluated in what's called the Warp Speed Project. As those gain FDA approval, it'll be rolled out in a phased approach. I believe the CDC director commented the other day that the mass public will be vaccinated probably by summer of 2021. But if you back into that, phase 1 is healthcare workers, high-risk individuals that we've talked about that are likely to have a more difficult time recovering from coronavirus. And information will continue to come out on that, and certainly we'll be here to educate what it looks like to get the vaccine, where that happens, and all of the process that goes around that administration.
And those studies continue to proceed. And the thing that people frequently ask me is it going to be safe to receive this vaccine once it becomes available? The important thing to realize is the corners are not necessarily being cut on how the studies are being done to look at, number one, whether it's safe, and number two, whether it's efficacious. And so all those processes are in place as they have been. The portion that has really been the warp speed, as they would call it, is really all the resources that have been poured into it, all of the logistics that have been poured into it. And then the other thing that is interesting is the vaccines have been produced already.
Right.
So what we know differs tremendously from previously is with other vaccines, when they come out, they go through a process of testing just like the COVID vaccine is going through right now. But then all of that is prolonged because then you have to get manufacturers that are going to produce it. Those manufacturers started producing months and months and months ago. And so there are lots and lots of vaccines that are currently available. And basically what's going to happen is as these studies progress and we find out which vaccines have been proven to be efficacious and safe, those vaccines are already produced and they'll be ready to distribute. And we've already gotten some guidance on being prepared to store those and how those will be administered and things like that.
Right. And it's all across the board from frozen to refrigeration, and it really is. It's a completely different way of thinking about how vaccines are produced. And I read one article. Vaccine production started in January when the first cases were reported. Not even in the United States until March, but we started seeing those in other parts of the world. Immediately, companies went to work in producing the vaccine. So I think there's a lot of thought that this is being done in 6 months. And really, it's going to be more like a year, which is still warp speed for vaccines. But as you mentioned, the resources being brought to bear are exponentially more. For the most part, many of these companies, this is a singular focus in get this vaccine to market safe, efficacious, and be able to move forward with being able to administer that.
The other thing that is different about this vaccine versus nearly other vaccines that were produced is essentially early on, once they had unlocked the genetic code of the virus, that was distributed worldwide. Right. And all of the scientists got together and said, hey, here's what we have, here's what we know about the virus, everybody go and start working right now. And that's very different than any other type of vaccine process we've ever been through. So number one, it's encouraging that our colleagues overseas basically unlocked that process early on and said, hey, here it is, let's all go to work and work together. But then also the companies that produce these vaccines started producing immediately.
Right.
The other thing that we talk about generally every week is testing, and there's lots of questions out there with regards to what tests we have, where those can be performed, and then what about all of these other tests? And one thing that we continue to stick with is we are sticking with the tests that are the most proven in terms of their sensitivity, their specificity, and we've adapted a little bit in terms of who we test and in what methods. You want to talk a little bit about that?
Yeah. So locations are convenient care out of Willow Plaza, as well as our medical center of Vincennes, seeing through your primary care. And then certainly anybody coming into the hospital is able to be tested. We've stuck with swabbing. So that's the Q-tip-like swab. Over the age of, 13 and older are nasopharyngeal, which is the long swab. And then 12 and under receive a nair swab, which is just inside of the nostril. What we know is that's the nasopharyngeal is the gold standard for detecting the virus as early as possible, and that our what's called sensitivity and specificity of those tests is that if the virus is present on the swab, we will detect it. What we have seen is what's called antigen testing and saliva testing have continued to gain popularity because of their speed of report. So within 5-10 minutes, you can get a positive, negative results, but the accuracy has waned a little bit on those. So we have continued from a healthcare standpoint to stick with what gives us the most accurate data for decision making. Our lab team continues to follow new developments, and as more point of care rapid results come available, we certainly will use those where appropriate. But right now, even when there are positive or negative results on those rapid test, there's a lot of confirmation that has to be done to make sure that we have the right information in making decisions.
And one of the things that we talked a little bit about earlier was the prolonged hospital courses that we've been seeing, and that brings up visitation policies. Mm-hmm. One of the challenges that we've had throughout this is trying to protect family members and trying to protect our community while still allowing family members to get in and visit their loved ones while they're in the hospital. And since we have seen that sometimes these sicker patients are in the hospital for longer periods of time, that's very challenging for families and very challenging for staff, because we want to make sure everybody stays safe, but we also want to give families the support that they need. You want to talk a little bit about our policies on that? Yeah,
so it's a delicate balance without question, and the safety of visitors coming in, the safety of patients, the safety of our team is paramount, and our team being able to care for these patients that require a lot of time in taking care of them. What we have done from a visitation standpoint is continue to look at that. That's a weekly conversation. We, at one point, had no visitors, nobody in the hospital. We didn't have enough information to allow that. We follow a lot of CDC and governmental guidance to say this is what you should do, this is what's recommended. Sometimes it's what's required. What we have moved towards is we're allowing one visitor on the inpatient floors, a visitor, or two if it's pediatric, allowing visitors in the ambulatory settings or going to surgery as well. And then as we get to the COVID positive population, unfortunately we have had some death. And so end of life scenarios, we do allow family, 2 visitors, unlimited time to be with their loved one. In that long stay, especially in that ICU, last week we started a process for communication where our medical providers, either one of our internal medicine residents or a member of the hospitalist, is calling the designated care provider at least daily. And then we have a member of our nursing team that's also designated to call and give an update. So it's at least 2 updates a day that's going to that designated care provider, sometimes more because, as we talked about last week, if there's a change in status,
Sure.
we communicate that, or if there's a need to perform a procedure or some activity, some test diagnostic-wise, then we talk to the designated care provider and make that decision. What we ask of the family is to create a communication phone tree, if you will, with your family, so that designated care provider, that medical representative, can communicate out to the rest of the family, allowing our team to have one point of contact. As of last week, that was working very well, had good positive feedback as that had moved forward. On the ICU, we also have allowed what are called window visits. So we have small windows in the doors that allow for, on a scheduled basis, to come in and see your loved one, have a few minutes to talk to the nurse or the physician on the team and talk about what the care plan is. We have been able to allow that, but we're still constantly balancing that risk of potential transmission and managing that. So far today, we have had 0 employees or visitors contract coronavirus, to our knowledge. I mean, there could be the cases that we don't know about, but from an active COVID patient here at the hospital. And our goal is to keep that number at 0 and protect everybody that's involved with the care of these individuals.
And as Adam mentioned, this is an ongoing conversation, and as we learn more and see how the processes work and get feedback, we are adapting to that. But that designated care provider is a super important person in terms of making sure that communication is good between our staff, the providers that are taking care of that patient, and then the rest of the family. And what it does is it really allows the care team more time to be with the patient and take care of the patient. And so we want to make sure that everybody is aware that it's super important early on during that hospitalization to designate that one point guard, that one contact person, and make sure that they're aware that they're going to be the person to distribute that information throughout the family.
And that's not specific to coronavirus.
Yeah,
I mean, that's something that everybody should have that plan. It's not necessarily something that you think about, but having that medical representative, if a loved one is in the hospital, is really important in any scenario.
Any other comments for this week, or would you like to go to the phones, go to the
Let's see what
iPads?
questions we have.
Yeah, we have one so far.
Okay.
Am I understanding correctly that the unique individual positivity rate is what is really important regarding what is currently going on in the community? We notice that the current numbers in hospitals in our county has continued to rise and seems concerning. How do you regard this? Obviously, you prefer people not needing to be hospitalized, but how concerned do we need to be over this increasing number?
Sure.
So,
So speak first to the first question. We focus on the unique individual because the all test is somewhat manipulated, is not necessarily the right word, but as more testing is pushed, that denominator grows, but the number of positive cases stays flat. That's going to drive that number down. Whereas unique individuals takes out those that are being retested, which we know from a retesting standpoint that you can test positive. After you've tested positive, you may test positive for up to months because of remnants of the virus, but that doesn't necessarily speak to active cases and risk of transmission. So unique is what we look at. We had a climb really through the month of September, and now we've seen that flatten off and are looking to be on the backside of that curve. I think the reason that's so important is because something we talk about a lot of times in healthcare are leading indicators. So one indicator is likely to lead to the next. So if we see increased community transmission, that's likely to lead to increased hospitalization at a period of time later, whether that's a week or 2 weeks. And that's where we start to worry about resources and certainly outcomes when somebody's in the hospital, that they're at higher risk for a bad outcome, whether that is long-term effects or even potentially death. So that's where we look at that. But I think right now I'm on the positive side of we're trending in the right direction. Those active cases are kind of a raw number to look at, and we know active cases are down from in the 60s to the low 50s. Hoping that continues to move in that direction. And then certainly, as you mentioned, the number of positive cases we look at are what age and what risk factors. Are they recovering at home? That's the preference. I mean, that's what you want to see, is that recovering at home and not needing additional resources such as hospitalization.
Yeah, and that positivity rate, if we went back 1 or 2 weeks, we were really watching our neighboring counties to these very closely, because their numbers were 19%, 20%, getting to the point where there was maybe even going to be a recommendation to shut down schools, so forth. Their numbers have dropped back down as well, 14.1%, ours 13.9%. We're continuing to see that drop down. So really just in the last week or so, we've seen that come up and then start to decline. And then the other thing we're talking about is that 7-day window, because when we talked for many months early on, we were looking at the entire time period from when we started this up until current date. And really what tells us more is that trend over the last week or so. And then as Adam was saying, the leading indicator, we look at that to know what's going to happen in the next week or two. And as we have followed along with number of hospitalizations, number of ventilated patients, we also will hope that now that we're seeing that number decline, that those numbers will go down as well. Capacity has never been stressed to the point where we were really worried that we were not going to have adequate resources. But over the last week or two, we were getting there. We were getting pretty close to being concerned about that. And the same thing has been true to the hospitals to the south of us, is that we're all watching that nearly on a daily basis to look to see what our capacity is to handle our normal patients along with our COVID patients.
And mentioning the other counties is a really good point, because from a Good Samaritan standpoint, we're a regional provider. So when we talk about Knox County numbers, which is certainly home and what we're focused on, there are 9 counties, Indiana and Illinois, that touch Knox County, and we have patients seeking care from all of those counties and sometimes even beyond. But we have the resources here to take care of that population. So if we see like percentages in a Davies, a Gibson, a Pike, or over into the Lawrence and the Crawfords in Illinois, those are resources we have to consider as well. So it's not just a singular county focus.
Right. That's it. Nobody woke up and got their coffee this morning to ask questions. All right. Well, thank you very much for joining us. We'll again be with you in about a week or so, and we'll be going on afterwards to answer any other questions that you have. Thank you.